I'm Alan Davis, a software engineer, a former cardiac nurse, and a senior lecturer in health data sciences at the University of Manchester. My goal on this channel is to make health data science, AI, and digital health understandable for clinicians, researchers, and anyone else who's interested in learning about this technology. I've experienced healthcare from several different perspectives or viewpoints. I trained as a nurse and worked in cardiac catheterisation labs, and today I teach health data science and informatics, including teaching people at various different levels and backgrounds, working currently in the NHS. But I also spent many years experiencing healthcare from the other side as a patient, and that's what I wanted to talk about in this video. I have a form of muscular dystrophy called FSHD, facioscapulohumeral muscular dystrophy. And firstly, I want to point out that none of what I'm going to talk about in this video should be considered as medical advice. I'm just sharing my experiences with the condition, and if you have any medical concerns, then obviously you should seek out a appropriately trained medical professional. So this condition is a genetic muscle disorder. It's a form of muscular dystrophy, and it causes progressive muscle weakness and wasting in various parts of the body. And many people, as I do, will have winging of the scapula, protruding stomach due to weakness in abdominal muscles and other muscle groups, and issues with things like reaching above your head with your arms, and often with things like walking. So people with this condition often need various aids such as orthotic devices or walking aids, wheelchairs, and in my case I also suffer from fatigue and chronic pain. There's currently no treatment that cures FSHD or stops the underlying disease, although many of the symptoms can be managed, and there's research ongoing into potential treatments. In my case, in the UK, it took over 10 years to get the correct diagnosis for my condition. During that time, I was repeatedly told that what I was experiencing was psychological, and I was actually diagnosed mostly by accident. A family member insisted that I go and see a physiotherapist. I'd seen many of these in the past. I humoured them and decided to go, and the physio mentioned that they'd seen something like this before, and they wanted to refer me to a neurologist who happened to be a friend of theirs. And he was able to tell just by looking at me and through clinical examination that I had the condition, but he also followed it up with a genetic test. So I wanted to talk about what healthcare looks like from these different perspectives, and what I've learned being the person sitting on the other side of the consultation. So typically we follow a broad pattern that might look something like this. The patient reports symptoms, the clinician interprets those symptoms and comes up with a working explanation, and then new information can be added to this which refines that explanation and ideally updates that explanation. And in my own case, once a psychological explanation had become part of the story, I sometimes felt that subsequent encounters were being interpreted through that existing explanation. So the model can start to influence how new information is interpreted. And rather than new information always causing us to reconsider the model, sometimes that previous information is retained. So another example of this is earlier in my diagnostic journey, I saw a shoulder specialist, and he told me that I had a congenital shoulder abnormality and suggested that I have some surgery done to shave the bone and increase movement, which I declined. And what struck me about this was that when I explained to him that I'd previously done a lot of karate in my youth and early 20s, and I was obviously able to, in the course of doing this, was able to put my arms above my head and hold my arms in that position, which to me implied that it wasn't congenital. This wasn't something I was born with. It's something that I was able to do, and then it sort of degenerated a bit later in life. He didn't really respond to that information, and the original explanation that he formed was retained essentially. So I'm not presenting that as judgment on an individual clinician many years after the fact. What interests me about that though now is the reasoning problem that it illustrates. So if our working explanation is that something has been present from birth, but the patient tells us they previously had function they've subsequently lost, should that new information not cause us to revisit and update the model accordingly? So we talk a lot in data science about models and that a model isn't real, it's a representation of reality. And this is also true with clinical records. Clinical data is not the patient. It's a representation of the patient created by a healthcare system. And it contains observations, measurements and codes, but also previous clinicians' interpretations and opinions. So in a way, clinical diagnosis is also a modelling process. We observe an incomplete set of information and we construct an explanation that best accounts for it. And a good model should change when sufficiently important information or new evidence doesn't fit with the existing premise. And once an interpretation enters the record, subsequent clinicians might encounter that interpretation as part of the patient's history and often repeat this. And this can be problematic if the information is not recorded correctly, such as perhaps they write down the left arm instead of the right arm or lung or kidney or whatever it is, and then such an error can persist throughout the record and get repeated in multiple places. An additional problem is that the working explanation can become data. So once congenital shoulder abnormality, for example, or psychological enters a clinical record, the next clinician doesn't necessarily encounter the patient as a completely fresh patient. When they encounter the patient, it includes that previous model of the patient or views built through that information. We talk a lot in healthcare about patient-centered care. I've experienced healthcare as a healthcare worker, as an academic and an educator, but also as a patient. One of the things being a patient taught me is that the record, the diagnosis and the data are all representations of a person. They're incredibly important, but they're not the whole person. And there are a lot of good and well-meaning people that work in the system, of course, and there are lots of issues and challenges too many to talk about in this short video and unpack them in any great detail. Healthcare systems in many countries, the UK included, operate under enormous pressures. There's workforce capacity issues, organisational issues, finance, technical and other pressures as well. And these pressures inevitably affect patient experience. The system in the UK relies on you getting to the right person. So usually the GP, the general practitioner, is the first point of contact for many people, but it's not always straightforward. We've got quite a specialised and focused system in the UK. So you could spend quite a long time going down a particular path. In my case, the person who finally recognised that something different might be happening wasn't another specialist that I'd been seeing for years. It was a physiotherapist, as I mentioned, who recognised a pattern that they'd seen before and referred me to a neurologist. So the things the clinical team might consider to be important as well might be very different to what the patient considers to be important. If we take the sorts of things that can be captured in an EHR, an electronic health record system, we might have things like the diagnosis, a list of medications, past medical history, appointments, allergies, test results, procedures. And that might be very important and relevant to the clinical team looking after a patient, but the patient might be concerned with completely different things. They might be concerned with things like how, getting dressed or getting to work or dealing with fatigue or pain, managing stairs, mobility issues, how to keep driving and staying independent, family issues, and uncertainty around the condition, especially with a degenerative condition, about planning for the future, dealing with change and all those sorts of things. And when complex or chronic conditions, we often see fragmentation, for example. So in my case, I've dealt with a lot of different people over the course of my condition: physiotherapists, orthotics, neurology, cardiology, GPs, pharmacists, various diagnostic tests as well, imaging across multiple different organisations, many of which don't share information or can only see some of that information. Often patients are asked to summarise the results of a test or visit which hasn't come through yet or isn't on the system, and that can be difficult and frustrating for patients as well. They don't necessarily understand how to report that accurately or what's important or what to pay attention to. And for those with additional concerns as well, other conditions, maybe if you've got hypertension, diabetes, it gets even more complicated. So although we can collect information like diagnosis, appointment history, medications, blood tests and so on, from a data engineering perspective, that's great. We've got this nice structured data, these nicely structured variables, but how do you capture things like I can no longer do something that I could do 6 months ago, or doing this is now taking me twice as long as it did before, or I've adapted how to do this so that a crude questionnaire it doesn't really cover that. You know, you either can or can't, you know, and it's more nuanced than that. And there is no straightforward answer for this, but there are things like PROMs, patient reported outcome measures, that can help to some extent to capture some of this information. These are standardized questionnaires that patients complete to record their views on aspects of their health. This could include things like their pain levels, fatigue, symptoms, quality of life, and so on. And I think this also brings in aspects of, you know, user-centered design and co-design when we're designing systems with end users in mind. For example, you might design a great patient app, for example, to monitor symptoms of people with this condition or something else like COPD. And you think it's great, and you go to a focus group and then they tell you that they find the graphs that you've produced quite depressing because it quantifies their decline and things they can no longer do anymore. So there's often tension between, you know, what can be done and what should be done. So again, a great reason to include patients in the design of systems and processes. You know, you might be very pleased of the graph that you've done from a technical point of view, but if it doesn't help the patient or it brings negative consequences, then again, it's worth exploring those things. With conditions like mine, where there's little to no treatment, other things become more important. So things like taking part in clinical trials, for example, and support from charities. In my case, that would be Muscular Dystrophy UK, for example. Having worked in healthcare and taught people who work in healthcare and lived with this chronic condition myself, I think the biggest thing about being a patient that's changed the way I think is focusing on questions that I ask. So I often wonder whether, you know, when we're designing a clinical service, collecting data, building an AI system, creating an app or doing any kind of research, I ask myself questions like, what value does this actually create for the patient? Because a healthcare system can record the diagnosis correctly, it can store the data correctly and can follow the correct processes, and all of those things matter, but the data isn't the patient. And ultimately what matters to the person may be whether they can get dressed or go to work or climb the stairs or drive their car, spend time with their family, or keep doing something that gives their life meaning, however they define what that is. And that's probably the most important thing being on the other side of healthcare has taught me. So if you are interested in learning to code, I've actually written some books on the topic, on learning to code and mathematics as well for clinical and health data sciences. So these are really written for people that are coming from a non-engineering and maths background, computer science background. They're for people coming from a health and social care background that haven't got that sort of formal mathematics and computing training that, you know, people that maybe come from that engineering sort of disciplines have. So it doesn't assume any prior knowledge and sort of starts with the fundamentals essentially. And the examples are in both Python and R, so you can pick which one of the two most popular languages for data science that you'd like to use. And if that's of interest to you, you can find links in the description below. Also, if you prefer something online, then I've got a free online short course in learning to code for people coming from healthcare background, also linked in the description. At the moment, this is just available in Python, but an R version is coming soon. In future videos, I'll discuss these roles in a bit more detail, as well as take a bit of a deeper dive into some of the technologies used and actually look at some examples of how we can apply some of these tools in practice.